Okay, we are going to do the second part of circulation, and I introduced you to blood pressure in the first one. So we're going to pick up with problems in blood pressure. The average blood pressure is somewhere around 110 to 130 systolic over 70 to 80 diastolic. Um, Hypotension is less than that, 110 over 70, 65, depends on what kind of condition you're in. The problem with hypotension is you don't have enough pressure to get blood to the brain, and so you get fainting and concentration problems. Now, on the flip side, the bigger problem is hypertension. Probably all of you go into hypertension, transient hypertension various times during the day when your blood pressure goes up, but we're mainly talking about chronic hypertension, hypertension that can affect your long-term health. So let me jump down to the effects of prolonged hypertension. We got a lot of things going here. This is going to increase the pressure in the blood vessels. It's going to increase the pressure against which the heart has to push the blood. So this also is going to put a lot of stress on the heart. It's also going to long-term damage the blood vessels in that they are under pressure continuously. And eventually those vessels can harden and become less elastic. Now, three organs where this is really life-threatening are going to be the heart itself, particularly if this is coronary arteries. You see a heart at the bottom. The brain in the middle, the cause of strokes. And by the way, there's a picture on the underside of a brain right there. You're looking at it, you can see the brain stem, and I've circled in yellow one of the arteries feeding blood to the brain, and that's where the stroke has occurred due to rupture of a blood vessel. And then the third problem organ is the kidney, and long-term damage to the kidney will cause kidney failure. All right, so there are two different kinds of chronic hypertension, primary and secondary. Primary is 90% of all hypertension. It's sometimes called essential hypertension. It has no one particular cause. Let me jump down to secondary. Secondary has a particular thing that is causing it. Therefore, the treatment for it is a lot easier. So let me give you secondary hypertension causes. Kidneys that cause hypertension. There is a hormone called renin, we're going to talk about in a minute, that if made unnecessarily by the kidney will cause secondary hypertension. Besides the kidney, there are adrenal glands. Remember that the adrenal cortex makes cortisol, and cortisol not only increases blood glucose, it will increase blood pressure. Third, thyroid, hyperthyroidism. T3 and T4 hormones set metabolic rate, can cause the SA node activity to increase, causing tachycardia and increased cardiac output and blood pressure. So there are three secondary hypertension causes. If it's not one of those, it's called primary. And primary, there are a lot of risk factors that accompany it. Obesity, diabetic, high salt diet, certain types of personality, what are sometimes called type A personalities, stress, obviously, inheritance, cholesterol deposition, sedentary lifestyle. All of those are primary. The treatment for primary and secondary varies. For primary, which is most common, very often they give things like Lasix or furosemide, which is its generic name, sometimes called water pills. It's a diuretic, eliminates water and electrolytes from the body and gets your blood pressure down that way. And there are other types of medications. If you look at the picture over here at the far right, you can see kidneys and aorta, iliac, arteries, and there's an aneurysm right there. Remember, when the pressure is high, it can cause damage to that blood vessel, and it can cause a weakening of the wall and a pooching out, I'll call it, of the wall, and that could potentially rupture. And if it happens right there, you're a goner. Okay, pressure in the vessels. Remember, arteries expand and they recoil. They expand, they recoil. They're able to accommodate higher pressure when they expand. Then when the pressure goes down, or when the blood flow goes down, they recoil. And this expansion and recoil maintains the pressure so there's not huge swings in pressure. I mean, it still goes up and down, but not huge swings that you would get if they were immobile, inelastic vessels. I've already talked about a little bit about diameter of blood vessels. Remember, they have smooth muscle. The vasomotor center in the brain controls constriction, sends sympathetic impulses to the blood vessel walls. The muscle constricts, contracts, and you get constriction. And that constriction means that there is going to be increased pressure on the inside of that blood vessel, increasing blood pressure. And when the muscle is relaxed, the vessel diameter is larger. That's vasodilation. Pressure goes down. We're going to talk more about pulse in just a second, but remember, when pressure goes up and down in the arteries, the difference between the high systolic and the lower diastolic is called pulse pressure. I've already mentioned that that's what you feel in the radial artery when you take a pulse. Capillaries, low pressure. Veins, very low pressure. This presents a big problem because, remember, pressure moves blood along, and when you have leg veins and gravity is pulling your blood down to the ground and it's trying to come up the opposite way, this low pressure is a real problem, getting the blood to get back to the heart. And remember that when venous return drops, then there's going to be less contraction of the heart with less volume, less stroke volume. So you've got a few mechanisms of return that help in return in the veins. You see one of them over here on that picture, valves. So actually you see two of them. You see the valves. The valves don't flip and move the blood along. Their job is to catch the blood as it begins to slide back down again, and the blood just kind of inches up and it pushes through the valve flaps, and the valve flaps just close again when the blood sinks, and it just keeps them from going down. You also see one other thing in this picture. You can see muscle contraction. So around all the blood vessels, you've got, particularly the veins, you've got lots of skeletal muscle. When the muscle constricts, contracts, and it becomes thicker, it squeezes in on veins, it helps to move blood along. Also breathing, particularly in the thoracic cavity, and the abdominal cavity, because your diaphragm goes up and down as you're breathing, it also pushes in on veins and moves blood along. Okay, pulse. Here's a look at different pulse points. I've mentioned the radial artery a couple of times. Here's some locations. There's also something called mean arterial pressure, or MAP. Here is the formula for it. It's diastolic pressure plus a third of pulse pressure. So here's an example. If your blood pressure is 120 over 80, then your diastolic pressure is 80. The difference between 120 and 80 is 40. You divide that 40 by 3. You add it with the 80, you get 93. So this is an indicator of good flow through organs. 70 to 110 is what you want. If it's less than 60, there's not enough flow. And if it's too high, then you could have a problem with edema, which we're going to talk about in a minute. So, factors affecting blood pressure. We're going to get more into blood pressure in a second, but here is a kind of an overview of things that affect blood pressure. Blood volume. If you're retaining water in the body, you're not eliminating urine properly, something's going on with the kidneys, that increase in blood volume will increase blood pressure. The second area you see, the heart. So obviously cardiac output, all important, remember cardiac output is determined by heart rate and stroke volume. Either one of those goes up, cardiac output goes up. Cardiac output goes up, blood pressure goes up. Resistance in the blood vessels. This could be from constriction of the vessels, vasoconstriction of the arteries, small arteries and arterioles. Smaller diameter means there's more blood coming in contact with the wall. That's increased resistance. It increases blood pressure. That's why one of the things your body does when you are losing blood and blood pressure is dropping is it does peripheral vasoconstriction. Viscous blood, way more blood cells per so much value, that increases resistance. And more blood vessels, the length of the blood vessels. So if you add up all your feet and feet and feet of blood vessels in your body, and let's say that you add 500, 200 pounds of weight to your body, all that adipose tissue requires more blood vessels, more blood supply. You would have much more length, total length of your blood vessels. That increases resistance and blood pressure. Those are the main things. Then veins can have a minor effect, but it's really these first three things. Okay, another problem area is capillary exchange. Okay, so we need to go over why there are exchanges of materials, particularly fluid, between the tissue area and the blood vessels. So let me point out a couple of terms here and define them. You got a blood vessel. Let's see, let me go to a marking system. Okay, so you have blood coming down this way, and out here you've got cells. We could be in the liver, or we could be in muscle, or we could be in, just depends, we could add adipose tissue, it doesn't matter. These are cells. And there is fluid in between the cells, and that's called interstitial fluid. By the way, the next chapter is going to be on lymph, and this interstitial fluid, just as a heads up, will eventually get caught up in the lymphatic vessels, and it's then going to be called lymph at that time. But anyway, that's getting ahead. All right, so pressure moves things. All right, now let me do the easy stuff first. Let's do solutes. Glucose. Obviously, let's see, let me change color here. Okay, to red. All right, so we have solutes of different types. In the blood. Glucose, sodium, potassium, amino acids, blah, blah, blah. And obviously their concentration is going to be less out in the cells because the cells need the glucose and need some of these ions and so on. So according to the laws of diffusion, these materials move from high to low, and they can easily move through the blood vessel wall into these cells. They first go out into the interstitial fluid, and then they move from the interstitial fluid into the cell. Remember that this is this wall that makes up the blood vessel. This is a capillary. It's only one cell layer thickness. It's easy to get through. Oxygen obviously diffuses. Now, there's things in the cells that have to go the other way. Waste products, carbon dioxide, a whole variety of things like that. Okay, so solutes, that's easy. The bigger problem is going to be water. Okay, that's what we're going to really focus on here. So, the three pressures that are involved with water movement. Various books call these by different names. So I'm going to use a couple of different names. Hydrostatic pressure, or capillary hydrostatic pressure. That is, the pressure inside of the blood vessel. It's the pressure of the blood pushing against the wall. All right? This big P is hydrostatic pressure. And that force is an outward force, pushing out as if you were in a little closet and you push your hands out against the wall, pushing outward. Obviously the wall's not going to go anywhere, but that's hydrostatic pressure. And that outward force is trying to push water, plasma, which is mostly water, outward. Outward being out into the tissue area. Okay, that's your hydrostatic pressure. Then you've got blood osmotic pressure, BOP, or sometimes called blood colloid osmotic pressure. And blood colloid osmotic pressure is, let me change colors, if I can get that bar down again, and I'm going to use green. Okay, so blood osmotic pressure is due to albumins. We covered this in the blood. These are large proteins. They are too big to get out of the wall of the blood vessel. They are inside of the blood. I'm making little green dots inside of the blood in case you haven't noticed them. You don't have these out in the tissue fluid. They're highly concentrated inside of the blood. Now, this is osmotic pressure. So remember, osmotic pressure, wherever you've got this solute, in this case albumins, there is going to be an inward force. I'm drawing green arrows inward, trying to pull water into the vessel. It's the opposing force to hydrostatic pressure. Then third, not as important, but here's the third one, interstitial fluid osmotic pressure. Out here in the tissue fluid, out here, there are a few little proteins and a few solutes, not as many as in blood, but they can help draw fluid out also. But the two major ones are going to be your capillary pressure, osmotic pressure, hydrostatic pressure, sorry, and blood osmotic pressure. Okay, so there's a layout of the pressures. All right, so here we go. Look at the blood vessel down at the bottom. All right, so here's your arterial end at the left, and the blood is going to be moving that way. And notice blood hydrostatic pressure. So inside of this blood vessel, the pressure is dropping. Remember, it's highest when the blood comes out of the heart. And the further away the vessel is with the blood, the lower the pressure is. So we start over here at this end. Remember, this is part of a capillary bed. It's just one little vessel. Starts out at 35 at the arterial end where the capillary bed begins. And then it's dropping, and it's dropping. All right, keep that in mind. The arrows show less blood hydrostatic pressure. Remember that this is a force outward, pushing fluid out. Then, at the bottom, you see blood osmotic pressure. It always stays somewhere around 25. It doesn't change. Remember, albumins can't get out of the blood vessel. They're stuck. So it's a constant osmotic pressure. Now, here's the key point. Let me erase all that and look at this. Down here at the arterial end of the capillary bed, look at the difference between the two pressures. It's about 10, right? And your stronger pressure is the outward pressure, hydrostatic pressure. The osmotic pressure is 10 millimeters mercury less, and so you have an overall force out, and therefore you get greater leakage of fluid outward. Remember, plasma, water. Now, a little bit further into the capillary bed, it's about equal. Now, go to the venial end of the capillary bed, things change. Now your dominant force is osmotic pressure, which is the inward, because now the difference is minus 9. All right? So it's not going to be pushed out. It's going to be pulled back in. All right. Now, in case you're thinking, okay, well, as much gets pulled back in as pushed back out. No, because if you look at these numbers right there, they're not equal. What's dominant? The outward. So there is always going to be a few molecules of plasma that get leaked out and don't get pulled back in. That's the key. So take a look at this. Here's another really good shot of it, because this shows you the two major pressures. Your hydrostatic pressure is the blue line with the blue arrows, and again you can see that pressure dropping. And then the red line with the red arrows is the osmotic pressure of the blood, and it's constant. And again, outward push Towards the left, greater fluid loss. At the venial end of the capillary bed, where it merges with the venial, your greater pressure is the inward osmotic pressure, but it's not exactly a one-for-one. One pushed out, one pulled back in. So, basically, in all your blood vessels, you lose about 2 liters of plasma a day. 2 liters, that's a half of a gallon. Now, in case you're thinking, well, I don't urinate that. No, that's not where it's going to go. It's going to go into lymph. And that lymph is going to eventually recirculate back into the blood. We'll cover it in the next chapter. Now, if you lose too much fluid out of your blood and into your tissues, you've got edema. That's accumulation of fluid out in the tissues. Okay, I'm going to stop there, let you think about this. The last section that we're going to work on, the third cardiovascular lecture capture, is going to be on regulation.